Well, good afternoon, everyone. We'll go ahead and get started. I want to welcome you to what I hope is going to be a very interesting session on obstetrical ultrasound. We're dividing this into two parts. I'm going to do the first trimester, and then Dr. Nkwako is going to go through anomalies in the second and third trimester. So let's go ahead and begin with first trimester. I do have a disclosure. I act as the medical director at Amherst Stat DX. Okay, so what are our goals for this talk? What are our goals in the first trimester? I think it's imperative that we always go back and look at what should we be including in our study. And what the ACR and AIUM says we need to document in the first trimester is document the gestational sac. Where is it located in the uterus? We need to calculate the mean sac diameter or measure the crown rump length. We need to date the pregnancy. Crown rump length is always more accurate than mean sac diameter. So if you see a little crown rumper in there, you want to measure that. You want to document the yolk sac. You want to document cardiac activity, and then fetal number. And here's a really important thing that we're going to go into depth in, and that is chorionicity and amnionicity. It's so easy to tell in the first trimester and so difficult later on. And then finally, we're required to go out there and look at the rest of the uterus, the adnexa, and down in the cul-de-sac. So these are our goals. Now, everyone knows that the human pregnancy is 40 weeks. But of that 40 weeks, the first two, the woman's not actually pregnant. We date the pregnancy based on the last menstrual period. So the first 2 weeks we call the ovarian period, where the follicle matures, the egg is extruded, and the corpus luteum forms. Now, at roughly day 14, we have fertilization. And Houston, we have contact right here. And now cell division begins, okay, until we form the morula, which is the 16-cell ball, then the blastocyst, where the cells layer out and a sac forms, and finally a trilaminar embryo by the end of this conceptus period. All of this is going on in the fallopian tube. Now, the blastocyst is actually where the cells start to layer out, and you have a gestational sac starting to form around it. Now, what is important here is once it gets into the uterus, this little thing literally excavates a hole into the endometrial lining. The importance is we can actually see this. Once this blastocyst has implanted itself into the endometrium, we get the very first finding we're going to see in the first trimester, which is the intradecidual saxon. Now, decidua really means endometrium. The word decidua, that's the thing that belongs to the mom. That is the endometrium at the pregnant uterus. Okay, so here is the intradecidual saxon. The key here is it is eccentric to the endometrial cavity. And that's going to help us tell an early intrauterine pregnancy from an ectopic pregnancy, eccentric to the endometrial cavity. So here we have just 4 different examples of the intradecidual saxon. And if you look where the walls are coapted, the sac is eccentric. So there's the walls, the sac, the wall, the sac. So in every one of these, the sac is eccentric to that cavity. And this is as early as 4 to 4.5 weeks that we can see this intradecidual saxon. Now on to the double decidual saxon. Now this is a little bit later. This was originally described with transabdominal scanning. And what you see here is we have at the bottom, at the base, the decidua basalis. Forming the capsule around this gestational sac, we have the decidua capsularis, and the remainder is the decidua parietalis. And together, this makes the double decidual saxon, with the double sac being the first sac is the gestational sac. The second sac that's ringing it is actually the endometrial cavity. And here's a beautiful example of a normal pregnancy going from a lovely intradecidual saxon, notice that it's eccentric to the cavity, which is right here, to a great double decidual saxon, with our inner sac being the gestational sac, the outer sac being the endometrial cavity itself, or endometrium, and this little line here, the hypoechoic line, that's actually the remaining endometrial cavity. Now, as you can imagine, this is a very transient finding, because quickly this wall coapts that wall and you never see it again later in pregnancy. All right, so as we move on, now this is going to help us determine a true sac from a pseudosac like you might see in an ectopic. Because in a pseudosac, it's going to be a central collection of fluid. You're going to see the decidua going all the way around it, as opposed to the double decidual sac sign. So let's look at this. When you look at this case, that might look like a pretty good sac, but what you see is, here's endometrium coming up, 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 and it's actually splitting around this thing. Look at it in the axial plane. There is the sac, quote, in the middle. It's really a pseudosac with endometrium going all the way around it. So that eccentric location is the first thing we're going to look for, and it's very, very helpful to us early on. All right. We've been talking about the decidua. We already said the decidua is the mom. That's the endometrium. Now we're going to go look in this sac and see what's going on with that developing embryo. And first thing, if you look up in an embryology book, you will never see the word gestational sac. We made that up. That's a totally made up word. What it truly is a chorionic sac. That is what it is embryologically. So the chorion belongs to the developing embryo. And this sac is lined with these little fronds here. And what happens is they start to regress in the area of poor vascularity, and they start to grow these little fronds down into the area of good vascularity, and now we have left this smooth area of chorion, which we call the chorionic membrane, can also be called the chorionic levy, and we have this frond-like chorion at the bottom, the chorionic frondosum. And the chorionic frondosum of the embryo and the decidua basalis of the mom is where the placenta is going to form. All right, so we can really determine that quite early. So now let's look what's going on inside our chorionic or gestational sac, because inside this sac is where the embryo is developing. And the embryo is attached to the chorion by this little stalk. At the end of the stalk, we have a yolk sac, and the embryo develops right on the yolk sac. Now, around this embryo is this tiny little amnion, this thin little amnion right here. Okay? So at this point, we have a giant chorionic cavity and a tiny, tiny amniotic cavity. With time, the amnion gets larger as the embryo starts to grow. The embryo will get a C-shaped contour. All right, notice that the amnion is now getting larger, but we still have a small amniotic cavity, a large chorionic cavity. Also notice that this little guy's starting to jettison his yolk sac here. The yolk sac's really important early on, but once you start getting circulation coming through this little stalk here, they jettison the yolk sac. A little further out, you can see the physiologic gut herniation here. Again, the yolk sac is being jettisoned into the chorionic cavity. The embryo is growing in the amniotic cavity. The other thing that you're going to notice when you scan is this chorionic cavity starts to become much more echogenic. And then finally, towards the end of the first trimester, the amnion is getting close to the chorion, but they do not fuse until early in the second trimester. All right, so what can we see by imaging? Well, the first thing we're going to see by imaging, whoops, we're going to keep moving here. First thing we're going to see by imaging is the yolk sac. You got to love the yolk sac. The yolk sac is so perfectly round, so easy to see. And we're going to see that by 5 to 5.5 weeks. Now, of course, there's a little embryo there. It's just below the resolution of our equipment at this time. But there's a little embryo growing in there at this point. Now we move to 1 week later, at about 6 to 6.5 weeks, we can now see the embryo. So by 4.5, we have a gestational sac, by 5.5, we have a yolk sac, and by 6.5, we have an embryo. And now we have what's been termed the double bleb or the diamond ring sign. The double bleb is one bleb is the yolk sac, the other is the amniotic sac, or the diamond ring, where the ring is the yolk sac and the diamond is the embryo. Notice here, this is our amniotic cavity, this is the chorionic cavity. Here's another one, and I just love this because it has everything in the world you could possibly want on a first trimester scan. Notice the thickening down in this area where we have both the decidua basalis and the chorionic frondosum. Then we have our double decidual sac with capsularis, endometrial cavity, parietalis out here. Then we have the yolk sac, the embryo, the amniotic cavity here, the chorionic cavity there. So we have just beautiful anatomy. As we get a little further out, the embryo is now growing. We have a nice C-shaped embryo. You can see the cord. Look at the amnion here. The amnion still forms quite a tight little capsule around there. It's like kind of baby in a bubble look. And the chorionic cavity is still larger than the amniotic cavity at this point. Notice that the yolk sac is outside the amnion. The yolk sac lives in the chorionic cavity. I have this flipped so it matches the diagram, but we can start seeing normal development. We see the lucency in the back of the head, which is the rhombencephalon. We see physiologic gut herniation here. This isn't a little sacrococcygeal teratoma. That's a yolk sac that's been jettisoned at this point. And you can see the amnion out there. The cord is already formed, already has the twists in it. The umbilical cord in the first trimester is roughly the same length as the embryo. If it's not, if it's short, that's a tip-off that something's wrong. The limb-body wall or the body stalk anomaly is going to have an abnormally short cord, and that's something that we can actually diagnose in the first trimester. The other thing I want to point out is when we look at this, look how clear the fluid is in the amniotic cavity, and the chorionic cavity, which is getting smaller and smaller, is now becoming echogenic. That chorionic cavity is filled with proteins and mucopolysaccharides that are actually quite sticky. And this is the reason we do not do amniocentesis in the first trimester. Because if you stick a needle through here and rip up a little flap of amnion, the back side of that thing is like flypaper. I mean, it can just glom on to a fetal extremity, and this is one of the ways that you can get amniotic band syndrome, and it's why we don't do amniocentesis. Well, now that we've talked about chorions and amnions, it makes sense now to look at multiple gestations, because I think this is now very straightforward, because it's so easy to tell chorionicity and amnionicity in the first trimester and so hard later in pregnancy. And remember that that's one of the things that we have to document by our guidelines is chorionicity and amnionicity. Well, you all know that there's two types of twinning. There's dizygotic twinning, which is actually the more common type of twinning, and there's monozygotic or identical twins. Now, the way I like to think about this is that these guys are roommates in this house. The uterus is the house, and these guys are roommates in there. And in this house, you have a kitchen, which is the chorion, because the chorion is what made the placenta, which is the kitchen. All right, and that the amnions are the bedrooms that these guys get to live in. Well, if you have to share a kitchen, things can go wrong. So ideally, you want each kid to have its own kitchen, its own bedroom here, and now they have this nice thick wall in between them. So if this guy's playing the stereo too loud, it doesn't really bother that guy very much. They really have very independent compartments that they're living in. But the problem is, what if you only have one chorion? You're monochorionic. You're sharing the kitchen. The problem here is, we've all had this, where you have a roommate and you bought the pizza, but the roommate ate it. And that's the problem that can happen in monochorionic twinning, is one of them can literally start stealing from the other. This is twin-twin transfusion. All right? And we're not going to go into that because that's a whole topic in and of itself. But that's the problem when you share a chorion. You're sharing a placenta. All right? But at least you got 2 rooms. All right? Even though it's a thin wall between your rooms, you have 2 rooms. What if you have to share not only a kitchen, you're monochorionic, but you also have to share the bedroom. You're monoamniotic. And now you're really going to get into trouble because these guys can get all twisted up, and they do, and those are cord accidents. All right? So now let's look at these by ultrasound. Obviously, if you're dizygotic, you get one of each. You get your own kitchen, you get your own bedroom. It's like living in a duplex, all right? So what we're going to see here when we image is obviously there's going to be a big, thick membrane between these 2 twins. Early on, you're going to see 2 intradecidual sacs, okay? Then here at 5.5 weeks, look at the thickness of this membrane. This is really, really easy to tell. 7 weeks, still very thick. Now we're in the 2nd trimester. Now the membrane out here is getting kind of thin, but we can see right here what we call the twin peak sign. Now somebody asked me, I don't get that sign. I mean, I only see 1 peak. Well, yeah, there's 1 peak, and there's 1 twin here and 1 twin here, and that's where the name came, the twin peak sign, the peak between the twins. So here we go, another one. Big, thick 1st trimester, twin peak or lambda sign here. That's easy. But I'm here to tell you it isn't always that easy. Because look at this one. Clearly dichorionic by the 1st trimester, but that's pretty thin looking in the 2nd trimester. So the later you get in pregnancy, the harder that determination is to make, and that's something you really want to do in the 1st trimester. We're actually required by our guidelines to make that determination. All right, what if you're monozygotic? Now what's happened here, 1 egg, 1 sperm, and then that fertilized egg split. All right? Now, my apologies to any identical twins in the audience, but this is actually an anomaly. Identical twins is an anomaly because that egg should not have split in a normal circumstance. Well, it really depends when it splits what's going to happen. If it splits by the 3rd day, now they're going to get one of each thing. They can still get a kitchen, a chorion, as well as the bedroom. They're dichorionic, diamniotic. All right? But after day 4, the kitchen's been built. All right? The chorion has already formed. They're monochorionic, but they still can each get their own amnion. After about day 8, now they're monochorionic, 1 kitchen, monoamniotic, 1 bedroom. They're all in that same sac. And then after about 14 days is when you get conjoined twins. All right, so here are our choices with a monozygotic pregnancy, so identical twins. Depending on when they split, these are our 3 choices in the appearance of their sacs. So obviously, dichorionic looks just like dichorionic in a dizygotic pregnancy. Easy, big, thick membranes. Monochorionic, diamniotic, thin membrane in between them, very, very easy in the 1st trimester. So monochorionic early on, you see 1 chorionic sac, 1 big thick membrane around the outside. You see 2 yolk sacs. A little tip, the number of yolk sacs equals the number of amnions, right? Because the little embryo grows on the yolk sac with the little amnion around it. It's just the yolk sac is far easier to see than the amniotic sac. So number of yolk sacs equal number of amniotic sacs. Later, about 7 weeks, you can see the amnions going around each of these. Notice that the yolk sac is out there in the chorionic cavity. So these are monochorionic, diamniotic. They each have their own membrane going around them. And then this is the rarest type, and the ones that get into the most trouble, and that is monochorionic. Notice one chorion. Monoamniotic, see this one membrane going around 2 little bodies right here. Notice that there is one yolk sac out there that we see. And and again, number of yolk sacs equal number of amnions. And then you look at this and we have a little embryo here and here. There they are in 3D, and everybody goes, oh, aren't they cute? They're all snuggled up there. Well, no, this is a disaster. And the reason this is a disaster is look where their cords are coming out. Their cords are coming out virtually at the same spot. So if we move ahead in this pregnancy, what we first see is we have 2 sections right through the fetal bodies here. Notice, and stomach here, stomach here. Notice how much bigger this guy is than this guy. I mean, baby Huey over here is really taking all the food from this guy. But that's not the real problem. The real problem is look at their cords. I mean, this is just a tangled mess of cords. And obviously, these are at risk for a cord accident, and that's exactly what happened. One of them strangled off the blood supply to the other, died in utero. They quickly delivered the living twin, and you can see the pile of cords there. And notice this thrombose cord from the one that had the in utero demise. All right? Well, hopefully, now this makes it very straightforward when you look at multiple gestations. Thinking about chorions and amnions, because clearly we have a triplet pregnancy, because we have 1, 2, 3 yolk sacs right there. Notice this big fat chorion right here, so it's dichorionic, triamniotic. See, these 2 are living in the same chorionic sac, all right? So chorions and amnions. Now on to our major discriminators. What are the things that we can hang our hat on that this pregnancy is doing well? Well, or not well. And those are, if you have a mean sac diameter, and I'm talking about by transvaginal scan here, greater than 10, you must have a yolk sac. If you do not have a yolk sac, that is a failed pregnancy. Now that's generous. Some people will use 8, and that's okay. Whatever your institution uses. I personally use 10. A mean sac diameter greater than 18 must have an embryo. And if you have an embryo in there with a crown rump length greater to or equal to 5, it must have a heartbeat. All right? So if you have let's say you have a mean sac diameter of 22 millimeters, and you have a yolk sac but no embryo, there's no point watching that pregnancy another week. You know that's a failed pregnancy. These are very good absolute numbers that we can look at. Now this heartbeat is very important. We can see this heartbeat really early. In fact, often we see the heartbeat before we even see an embryo to measure. Now it can start off a little slower. All right, but it really ramps up very quickly to the mid-hundreds. And we notice here this one has a heartbeat of 178. And that's where they should be by the middle of the first trimester. If it's less than 100, I start to worry a little bit, and I may well get a follow-up on that. And remember that by 5 millimeters, you have to have a heartbeat. The way I like to teach my residents is you must be alive by the time you're 5. All right? So you got to have a heartbeat by the time you're 5 millimeters. Why can we see the heartbeat so darn early? You can see a heart beating before there's even anything to measure. That's why that 5 millimeter measurement is actually quite generous. Well, this is you in your salamander phase of development. Here you have little gills here, little tail coming around, and you're wrapped around this basketball. And that basketball is actually your heart. And what you're actually seeing is that as this squeezes, that whole little embryo blips up and down. So you're actually seeing the whole little embryo move. And you can pick up things in there before you, like I say, before you even see anything. Here we saw something blipping in there, nothing we could measure, but it's blipping at 139 beats per minute. So you know that's a living embryo in there. All right, woman comes in, and she is pregnant. This is just routine dating, no bleeding, no cramping, no nothing. All right, 5.5 millimeters. Okay, well, I've been nothing if not dogmatic about saying you must be alive by the time you're 5. No heartbeat, okay? Well, she goes home, and lo and behold, no bleeding, no cramping, nothing goes on over the next week. And they check her HCG, it's going up in a normal fashion. She comes back and there was a normal little embryo there with a heartbeat. Well, what the heck went wrong here? Well, you'll notice this is this, and that is a polyp. All right? And that is a potential pitfall. However, if you really look at this, where is this in conjunction to the yolk sac? Where does the embryo grow? The embryo grows on the yolk sac. So it doesn't grow on the opposite wall from the yolk sac, so this shouldn't be a pitfall to fall into. But these endometrial polyps can indeed be confusing from time to time. All right, let's look at a normal pregnancy develop here. This woman comes into the emergency room and she's having some abdominal pain. HCG is positive. She has barely missed her period. Okay, 4 weeks. Now notice the time, it's 2:22 a.m. because no one comes ever in for rule-out ectopic during the day. They all come in the middle of the night. So the resident scans her, and resident number 1 I actually think has a difficult decision here because we have this decidual reaction of the endometrium. We have some free fluid, but we don't see a sac. This absolutely could be an ectopic, and it clearly needs to be correlated with what the HCG is at this point and with her physical symptoms. So at this point, by imaging, we can't tell intrauterine pregnancy from ectopic. All right, so she goes away, and she comes back 4 days later. Now, when she comes back, it's now earlier, but it's still off hours. It's 8 p.m. here. All right, so resident 2 scans her. Now, resident 2 has it infinitely easier than resident 1 because what we see now is a little sac, an intradecidual sac sign right here. Here's the endometrial cavity. In fact, we almost have a baby double decidual sac, don't we, with the gestational sac and the endometrial cavity there. All right, so now we're feeling much better about this. But so she goes home and shows up again a week later. Obviously, 8 p.m. was a convenient time because that's when she's in. And resident 3 now scans her. And now we're 5 weeks, and right on cue, now we have this beautiful yolk sac. You gotta love the yolk sac. That tells you for sure this is an intrauterine pregnancy. And so we're feeling pretty good. She now goes away, comes back, and all right, it's 2:30 in the afternoon, but guess what? It's Saturday. Resident number 4 scans her at this point. Now, resident 4 doesn't do a transvaginal scan, but that's okay because this is a well-documented pregnancy. We now see a little embryonic pull there, yolk sac, 6 weeks, 6 days. My point here is things change drastically in the first trimester in a very short period of time. And short follow-ups, 2 to 3 days, you can see dramatic changes in a normal pregnancy. Cell division at this time is astronomical. No tumor in the world divides as quickly as a first trimester embryo. And I saw some statistic that if cell division continued at this rate, that the baby at delivery would be something like 3,000 pounds. I mean, it is an astronomical rate of cell division, and things do change drastically. All right, what constitutes an abnormal first trimester scan? Well, let's see. dead is right at the top, all right? So if you have no heartbeat, more than 5 millimeters, that is a demise. Now, bradycardia is also a very bad sign in the first trimester, and then we're going to go over some of these other things too. So here we have a heart rate 70 beats per minute. Now, I said it can start slow and ramp up. 70 is very slow. I'd be very worried about this. You bring her back 3 days later, and you don't see the yolk sac anymore. Essentially, this is now an anembryonic pregnancy. Speaking of which, when do we make that declaration? Again, our absolutes, greater than 10 without a yolk sac, greater than 18 without a fetal pole. We can look at the decidual reaction, the shape, and all of that, but those are just ancillary findings to our major discriminators here. Now, just a word about terminology. Anembryonic is a fine term. Failed first trimester pregnancy is a very good term for kind of encompassing all of this. You may see in older textbooks the words blighted ovum. That's out. In our age of political correctness, you cannot hang it on the ovum. It could have been the sperm. And in either event, it wasn't that that's blighted, was it? It was a zygote, right, or an embryo at the time. So, and here are just 3 different anembryonic pregnancies, irregular sacs, all of them. Some other thing you might see is the empty amnion. See the chorionic cavity, the yolk sac, the empty amnion. Remember in our normal ones that the amnion really made a little bubble around the embryo in there. We would expect a large embryo in there for the size of that amnion. So just at first glance, you know that is an abnormal pregnancy. And there's just an empty amnion right there. And just 3 more examples of empty amnions and irregular sacs. Perigestational hemorrhage is another thing that we can see. Here we have our double decidual sac, but in the endometrial cavity there, you see this echogenic debris. That's blood. Now, hemorrhage in the first trimester is kind of an all or none thing. This will either resolve and the pregnancy will do fine, or they're going to go on to miscarry. Unfortunately, in this case, a few hours later, this extended, the sac is collapsed, and she went on to miscarry. You have to look very carefully on some of these because they can often be almost isoechoic. And you see this one, it's a fairly large subchorionic hemorrhage here, but several weeks later it's gone on to resorb, it's become more hypoechoic there, and this pregnancy did just fine. Again, you got to love that yolk sac. Easy to see, and it's got this wonderful round appearance. And if your yolk sac's not looking good, that bodes poorly for the pregnancy. If it's too large, if it's irregular, calcified, etc. And here we have a case, this embryo was bradycardic, all right? And notice that the yolk sac was huge. The yolk sac's almost 8 millimeters here. This one went on to demise. Growth is unbelievably symmetric in the first trimester. There is no diversity. So it doesn't matter if you're going to be Wilt Chamberlain or Willie Shoemaker and be a basketball center or a jockey. When Wilt and Willie were both 6-week embryos, they both measured 1 centimeter. There is no biologic variation manifested in the first trimester. And we can use this to our advantage. Because here we have an embryo measuring 3.8 millimeters, no heartbeat. Well, we're not feeling very good about this pregnancy, are we? Because we usually see a heartbeat before we can even measure anything. And by the way, if this is almost 4 millimeters, that yolk sac is gargantuan over here. All right, so do we want to bring her back the next day? Well, no. If this were normal and growing normally, the next day it'd be 4.8 millimeters, and I don't have to see that heartbeat till 5, right? So I want to at least wait at least 2 days and probably 3. When I bring her back, the sac is now collapsed. And then finally, what we have to include in the first trimester scan, we've got to look at the uterus, adnexa, and cul-de-sac. You want to look all around the uterus. This was interesting. You see this bright echogenic line in here. This little guy, he was having fun. He was doing little backflips over this. It was like having gym equipment. That's an IUD. Now, not a very good IUD, mind you, but it's an IUD nonetheless. Other things you got to look for, fibroids is a really important one. Here's a large cervical fibroid here. Fibroids can grow, they can infarct, they can cause pain. So we want to document fibroids. They can obstruct labor. Here's one that has undergone cystic degeneration right here. So they're very important to document. All right, so in summary, I just want to leave you with the fundamentals of the first trimester ultrasound. It's important to know what we have to document and what the normal development looks like. And if you have that firmly implanted in your minds, then I think it's very easy then to look for abnormal development.